Hello and good afternoon, everybody. I hope you all are staying home, staying safe, and fighting COVID-19 effectively. Today, we are going to talk of a fairly common condition, especially in geriatric age group, senior males, that is benign prostatic hyperplasia. This benign prostatic hyperplasia comprises a fairly common condition. In the male over the age of 50 years, this usually becomes more common with advancing age, and at the age of around 60 years, 50% of the males will start having some or other histological evidence of benign prostatic hyperplasia. At least 15 to 20% of them have significant lower urinary tract symptoms. What causes BPH? We know hormones play the most important role. Testosterone is the predominant hormone in males, and estrogen is the predominant hormone in females. With advancing age, the levels of testosterone will start going down slowly but significantly in case of males. And at the age of around 50, you will find that at least 50% of the males will have so much significant decrease in the testosterone levels that the estrogenic hormone will start becoming predominant. Now it is important to remember, with advancing age, the level of estrogen is not going to increase in males, but the level of testosterone will go down. Now, previously it was like this. Testosterone was like this and estrogen was like this. Now what has happened is, with increasing age, the levels of testosterone has gone down significantly, so that the level of estrogen has not yet actually increased, but still it becomes predominant. And the action of estrogenic hormone is glandular development. Now that is the reason why the females are having different breast size and shape as compared to male, because estrogen is the hormone which is responsible for glandular development. Breast is a gland, therefore you will find that the breasts are developed in case of females as compared to males. Now prostate is also a gland, and similar to that of breast, with increased estrogenic predominance, the prostate will start undergoing development. In short, we start calling it as benign prostatic hyperplasia, or in short BPH. What is the pathology of this BPH? We know BPH affects both glandular epithelium and connective tissue stromal to variable degrees, and these changes are, you can compare it with the breast dysplasia. Now, where in case of breast dysplasia, we know adenosis will occur, epitheliosis will occur, and we term all these things as fibroadenoma of the breast, which is again a fairly common condition. You can compare prostatic changes similar to that of changes in the breast, which also are hormonal in most of the instances. This BPH will typically affect submucous group of glands, and it will actually start in the transitional zone. Now, when the BPH when we talk of effects of BPH, we have to understand three things. Number one, it is the anatomical enlargement of the prostatic gland. Number two is symptoms of prostatism. And number three is whether there is any urodynamic evidence of bladder outflow obstruction. Because these three things, you understand it nicely please, these three things are having very important role when you talk of BPH and its treatment. Means what? Sometimes there may not be any symptom and there may not be any bladder outflow obstruction. In short, I will call it as boo now onwards. So no symptoms, no boo. That is one possibility. Another thing, BPH can cause no symptoms, but there is urodynamic evidence of bladder outflow obstruction. Number 3, there can be symptoms of prostatism. However, there is no evidence of bladder outflow obstruction. Number 4, there can be both. Symptoms are also there, BOO is also there. And number 5, along with this, there can be other things like there can be acute retention, chronic retention, episodes of near retention, there can be recurrent UTI, hematuria, stone formation due to BOO, etc. So, we have to understand that the effects of BPH will be different when you talk of different people. Now, we have to understand one thing, that all the symptoms of prostatism may not be because of prostate in old age. In old age, there are other conditions. There can be neurogenic bladder, there can be Parkinson's disease, there can be Alzheimer's disease, there can be degeneration of the bladder smooth muscle, and these, because of old age, all these symptoms may not be attributable to BPH only. So, while the patient describes all these symptoms, we have to make sure whether it is because of BPH or it is something else. Now, basically, we are going to divide the symptoms of BPH into two types. One is irritative group of symptom and one is obstructive group of symptom. The irritative group of symptom is caused by irritation of the bladder neck because of the increased mass of prostate. Obstructive group, as the name suggests, will be caused by actual obstruction, mechanical obstruction by the increased mass of prostate. What are the things in irritative group? We all know it. It is frequency, urgency, nocturia, urge incontinence and nocturnal incontinence. These 5 things are they are different from each other. Like, we know what is frequency, we know what is urgency. But what is nocturia? Nocturia is the number of times the patient has to get up in the night for urination. That is called as nocturia. Normally there should not be any incidence of getting up. However, the patient of BPH may get up even 5-6 times in the night. There can be number 2, nocturnal incontinence. There is a difference between nocturia and nocturnal incontinence. Nocturia means patient will get up for micturition at the night time. Nocturnal enuresis or nocturnal incontinence means bedwetting. It can occur in geriatric age group also. And the last in the list is urge incontinence, means when the patient feels like going for micturition, by the time he will reach the lavatory, he will pass a few drops in the clothes itself. That is called as urge incontinence. So when you talk of irritative group of symptoms, there are 5 things: urgency, frequency, nocturia, nocturnal enuresis, and the last is urge incontinence. Now when you talk of obstructive group of symptoms, it also comprises 5 to 6 things. Number 1 is hesitancy. What is hesitancy? Hesitancy means the patient wants to go for micturition. He will actually go there, but urine will not start flowing immediately. That is called as hesitancy. Number 2, there can be poor flow. So the patient's urinary flow will start, but the flow is not strong enough. It is a poor flow. Number 3, there can be intermittent dribbling, like the urine will start and it will again stop, and then it will again start intermittently. Number 4, there will be dribbling of the urine. Usually, we all know what is dribbling. The patient will describe it as drop by drop urination. Number 5 is sensation of poor bladder emptying. So the patient will typically say की डॉक्टर लघवीला जावंसं वाटतं, लघवीला इतकी घाईची लागते की असं वाटतं लगेचच्या लगेच एका मिनिटात जावं, नाही तर कपड्यांमध्ये होईल. परंतु गेलं की बराच वेळ उभं राहायला लागतं, मग लघवी सुरू होते, बऱ्याच वेळेस थेंब होते, लघवी चालू होते, थांबते, पुन्हा सुरू होते. ऑल दिस थिंग्स विल डिस्क्राईब ऑब्स्ट्रक्टिव्ह ग्रुप ऑफ सिम्पटम्स. आणि सगळ्यात महत्त्वाचं पेशंट सांगतो, लघवीला जरी जाऊन आलं तरी काही लघवी शिल्लक राहिली मागे, सेन्सेशन ऑफ पुअर ब्लॅडर एम्प्टिंग असं वाटत राहतं. And the last in the list is episode of near retention. So patient will not be able to pass urine for 2, 3, 4, 5 hours. He will feel as if now the urine is obstructed, retained, and then he will go and there will be a passage of some amount. So this is called as episode of near retention. So this is about the clinical features, irritative and obstructive group of BPH. Now, how do we assess the patient of prostatism? So, assessment of the BPH patient can be done by physical examination and by blood investigations also. Physical examination includes abdominal examination, which usually doesn't reveal much except for a distended bladder in case of urinary obstruction. But very important physical examination is per rectal examination. Per rectal digital examination after proper lubrication usually gives sufficient information, and in skilled hands you can also make a suspicion whether the patient is having only BPH or whether there is some possibility of cancer of prostate, because that typical feel which you get, stony hard feel, usually makes us suspicious for CA prostate. So now when we talk of investigations of BPH, the first is serum PSA, that is serum prostate specific antigen levels. But one thing should be remembered, that these blood samples for PSA should be collected before per rectal digital examination. कारण की जर पर रेक्टल डिजिटल एक्झामिनेशन केल्यानंतर तुम्ही सॅम्पल कलेक्ट करण्याचा प्रयत्न केला तो यू विल गेट false high levels of PSA and you can get misguided by the false results. Number 2 is flow rate measurement. But this flow rate measurement, this investigation should be done with an accurate machine with accurate calibration. More than 150 ml of urine should be voided every time by the patient on 2 or 3 occasions for proper interpretation of the results. Third investigation is urine routine. Fourth investigation is blood investigations like CBC, hemoglobin is important, serum creatinine, serum electrolyte levels, sugar, etc. Imaging in the form of ultrasonography of abdomen and pelvis, especially pre and post void residual urine should be looked for. This post void residue will give us an idea how much obstruction prostate is causing, if at all. And the last in the list is cyst urethroscopy. So cyst urethroscopy means a scope is passed in the urethra and the urinary bladder for accurate diagnosis of prostatic conditions. Actually, ultrasonography of the abdomen and pelvis is one investigation. In the same context, we can say that if at all we on per rectal distal examination we feel that the patient is having some kind of irregular nodularity in the prostate, we can advise the patient to undergo transrectal sonography of prostate, and the same can be followed by transrectal biopsy of the prostate. So these are the investigations. Now, how we are going to manage the people with BPH? So the treatment part includes conservative management and operative management. Now, conservative management includes all kinds of medications. In allopathy, the most commonly applied medication is alpha adrenergic blockers. Another group is 5-alpha reductase inhibitors. Tamsulosin you must have heard of. Tamsulosin, dutasteride. These are the drugs which are commonly used. But these drugs should be taken for a very long time. Over months together we need to give these medications for their proper effect. If the patient is not responding to the conservative line of therapy, then the patient will require operative management. Sometimes if the patient is already having very severe symptoms, if the patient is having acute retention, acute on chronic retention, episodes of near retention, then we may not even think of giving conservative management, and the patient can be directly subjected for surgery. The most common form of surgery done for BPH is TURP, that is transurethral resection of prostate. However, there are other ways of doing it. It can be retropubic prostatectomy, or it can be laser therapy. So with the help of lasers, we can actually abolish. This laser treatment is specially useful to prevent complications of operative management. Now, what are the complications of operative management of BPH? They are multiple. Number one is hemorrhage. Number two is sepsis. Number three is what you can call it as incontinence of the urine. The bladder neck, when you are operating the patient on, the bladder neck may get scarred and you can develop bladder neck contracture. Then there is something called as urethral stricture. There can be retrograde ejaculation. So all these complications in skilled hands, of course, the incidence of complications is less, but the complications can definitely occur, and the patient should be counseled before subjecting the patient for operative management. So that is about BPH. There is one more topic in the same context, that is CA prostate, that we'll be talking of in the next lecture. Right now, this is all about benign prostatic hyperplasia. If you are having any doubts, please let me know. Thank you.